Hi everyone, and thanks so much for coming to my grand rounds talk today. It's always fun to present early in the year. For those of you who haven't met me yet, who have not had the pleasure of working with, I'm Ben Lidgard. I'm one of the K-funded assistant professors. My research really focuses on the intersection of kidney disease, lipid and metabolic factors, and then cardiovascular disease. And I'm excited to discuss the results from a study that our group wrapped up over the summer, looking at the associations of sphingolipids with death in the hemodialysis, or hemo for short, study. And thanks to Simon, my nerd brain got thinking about Star Wars. And since we're thinking about sphingolipids in patients treated with hemodialysis, I started thinking about this study as the Sith study. If you recognize this character, that's amazing. If you don't, I'll loop back to the analogy a little bit later. I don't have any relevant disclosures for today's talk. And here's just a brief layout for what we'll discuss. We'll talk about the background briefly. What are sphingolipids? Why might they matter in patients treated with dialysis? We'll talk about our hypotheses and what we thought we were going to see. We'll talk about our methods, how we investigated the study, and then the results. And we'll spend a little bit of time talking briefly about where we're planning to go next. And in discussing patients suffering from kidney failure, we're all very cognizant that they're subjected to extremely high mortality rates. And this is data from the United States Renal Data Survey, or USRDS, demonstrating roughly a 20% one-year mortality rate and nearly 60% mortality at 5 years after dialysis initiation. And most of the deaths here are going to be from cardiovascular disease. No surprise to this group, myocardial infarction, heart failure, stroke all play a role. But as we know, the lion's share of deaths are really thought to be due to arrhythmia or sudden cardiac death. And in the general population, and those with chronic kidney disease not requiring dialysis, low-density lipoprotein cholesterol, or LDL-C, is a major risk factor for cardiovascular disease and all-cause mortality. However, unfortunately, lowering LDL-C has not been associated with cardioprotective effect in patients with kidney failure treated with maintenance dialysis. This was a subgroup analysis from the SHARP trial, demonstrating that lowering LDL-C not associated with better outcomes in dialysis patients. This was confirmed later by the 4D study. So if lipid biomarkers are indeed important in this population, we might just be looking at the wrong ones. We might need to look at different lipids. Fortunately, there's a lot of lipids out there. This is kind of a brief overview of the kingdom of lipids. There's a lot of different lipids. You've got your fatty acids are kind of the basic building blocks of a lot of different fatty acids. Triglycerides are essentially three fatty acids on a stick. These two groups are kind of like food sources for molecules, proximal tubules included. You've got steroids, which are your classic bioactive signaling lipids. They're built around this multi-ring backbone. The sphingolipids we'll talk about in a little bit more detail, and then the glycerose phospholipids are another big class that not much work has been done on. There's been a decent amount of work looking into fatty acids and triglycerides and steroids, and there's been increasing interest recently in sphingolipids. And they're an attractive class of lipids for several reasons. First of all, they're named after their resemblance to the mythical Sphinx. That's attractive right there. Also, this is a class of lipid molecules that has structural, regulatory, and signaling roles. So these are genuine bioactive lipid molecules. And these are characterized by the sphingosine D1 backbone. This is the most common in human serum, so we kind of assume the presence of the D1 backbone. And then we call sphingolipids by their functional subgroup, ceramides, hexacyl or glucosyl ceramides, lactosyl ceramides, or sphingomyelins, shown over here on the right side. They have a phosphatidyl group. And then the number of carbons and double bonds in their acylated fatty acid, or R chain. So if we took fatty acid 16-1 and acylated it onto ceramide here, we'd call this ceramide 16-1. And part of the thought of why sphingolipids might be associated with cardiovascular disease and all-cause death is that there's pretty good basic science evidence that they could be directly cardiotoxic. So these are data from bioengineered mice that overexpressed long-chain acyl-CoA synthetase, specifically in myocardial tissue, as we see on this Western blot. And this allowed greater lipid droplet accumulation in these cells, demonstrated by this oil-red-O stain. And when we looked at what types of lipids these were, they're mostly ceramides, especially ceramide 16-0. And the mutant mice developed a dilated cardiomyopathy pattern and they had greatly shortened lifespans. Here, the lowest curve is a full overexpression model. The middle line is kind of a partial overexpression, and the top line is a wild type mouse for comparison. So, pretty compelling evidence that more ceramide 16 uptake in mice leads to dilated cardiomyopathy and death in mice. There's some data from epi studies in humans that these lipids might be cardiotoxic as well. So this was from Rosen Lamatter's group, published in JAMA Network Open in 2023. And this basically showed that sphingolipids with 16-0 species were associated with a higher risk of sudden cardiac death. And we found specifically in patients with chronic kidney disease that just the HDL component of sphingomyelin 16 was also associated with an increased risk of death. And this is specifically in chronic kidney disease patients, not dialysis requiring, but getting closer perhaps to that physiology that we're looking for here. And it seems likely that sphingolipid concentrations might change by stage of chronic kidney disease. We lack longitudinal evidence from multiple patients to see how things change in parallel. But compiled across a large amount of different studies, we see that there tends to be, with worsening CKD, more sphingolipids with long chain fatty acids. That's those 14 to 18 carbon R chains, and lower concentrations of those sphingolipids with 20 plus carbons, or the very long chain fatty acid sphingolipids. So, inspired by our prelim evidence, our prelim data, and then kind of the trends that we've seen in general populations, we hypothesized that greater concentrations of sphingolipids with long chain fatty acids would be associated with an increased risk for death. And those sphingolipids with very long chain fatty acids would be associated with a decreased risk for death in this population. Right. So we've talked about the background, we've talked about our hypotheses. Let's dive right into the methods and how we tested our hypotheses using the hemo study. So the hemo trial, or hemodialysis trial, was a 2-by-2 randomized factorial multi-site trial in the United States, testing the effect of dialysis dose and dialyzer flux on all-cause mortality. And at the end of follow-up, there was no difference in all-cause mortality, maybe a slight difference in cardiovascular mortality, but the confidence interval included 1, so most people think about this as a negative study. A major strength is that all the deaths were doubly physician adjudicated, and this was a 1990s study, right? Participants were enrolled between March of 1995 and October 2000, so a lot of the practices of the time are going to be reflected in the data that we actually have. So in order to measure the sphingolipids that we have listed over here on the left, we asked that the NIDDK send us the baseline serum for all available participants in the hemo study that had it. They aliquoted the specimens in Bethesda, they put them on a plane on dry ice, flew them over to Seattle, and then Andy Hoofnagel's lab thawed them out and measured the sphingolipids that we have listed with liquid chromatography tandem mass spec. We modeled these sphingolipids then as individual sphingolipids, classes of sphingolipids, and then the ceramide risk score, which I'll talk about a little bit later on. Our primary outcome here was all-cause death, and our secondary analyses were cardiovascular and non-cardiovascular death. And although this is a little bit of a morbid question, I thought it was worth going into because hemo did it pretty well. And it's fairly important to understand for our analyses. So, in brief, the site coordinators compiled data on each death occurring in the hemo study. And these reports that they compiled were fairly detailed. They included hospital records, ICD codes, clinic and dialysis unit notes, diagnostic tests, which included EKGs, echoes, any imaging studies, like MRIs or CTs, cardiac cath results, family accounts, physician accounts, death certificates, death notification forms to the USRDS, and autopsy data if available. And there's actually a fair amount of autopsy data available. And then all of these deaths were doubly physician adjudicated. And if there was any disagreement whatsoever, the death would be adjudicated by the entire outcome review committee. And then the types of deaths were lumped by the hemo study into cardiovascular. This was myocardial infarction, heart failure, arrhythmia, and then valvular or other, usually like a pericarditis type of event. And then non-cardiovascular death. That included stroke, peripheral vascular disease. We had infections in there, withdrawal, GI bleeds, malignancy. Anything that wasn't one of these four types of diagnoses was a non-cardiovascular death per the HEMO study. And we tested the associations of sphingolipids with each of these outcomes using Cox regressions. So let's talk about our results, briefly what we saw here, and then we'll spend a little bit of time talking about our next directions. This is the first part of table one, looking at overall characteristics. I'll highlight the things that's important to note here. So the mean age was 56, slightly more Black than white participants, and then most participants were from the Northeast, Southeast, and Midwest regions. We see here that the median dialysis vintage rather was about 2 years. So these were people relatively young, relatively healthy. They survived on dialysis for almost 2 years before getting into the study. So they're already a fairly healthy population. And then if we look across the quartiles of ceramide 16-0, we see that those with ceramide 16-0 in the highest quartile tended to be more likely to be women. They had slightly longer dialysis vintage and less urine output, though this variable was highly missing in about 2/3 of participants, so take it with a grain of salt. These are the remaining baseline characteristics. Those with greater ceramide 16-0 tended to have more heart failure prevalent at baseline and higher total cholesterol. There's a couple of big things that I wish we have, but we just don't have. We don't have fasting status, we don't have lipoprotein levels, and we don't have statins. And again, this was in the 90s. Hemo started enrolling in 1995. This was a decade before 4D was published and about 16 years before SHARP was published. Lipoproteins and statins were not on the forefront of everyone's mind in the 90s in dialysis patients. So if you've been to one of my talks before, you've probably seen some kind of figure like this. We know that sphingolipids are positively correlated with each other, and this is because of the basic machinery that creates sphingolipids. If you make the basic sphingosine or sphingonine backbone, you have an opportunity to make all the sphingolipids because you've got the substrate floating around. And some of the ceramide synthetases will actually isolate on backbones that are a similar length, like 22 and 24-0. So we see strong correlations here between ceramides 22 and 24-0 and sphingomyelin 22 and 24-0. We also see that there's fairly strong correlation just within these functional subgroups, right? All the ceramides are correlated with each other, all the sphingomyelins are correlated with each other. So just a thing to note here. And these are the deaths that we observed in the hemo study, and these are the causes of death as adjudicated by hemo. So over a median follow-up of 2.42 years, there were 376 deaths, quite high, but again, this is dialysis. Of these deaths, nearly half, 186, in fact, were cardiovascular death, and 190 were non-cardiovascular death. And we see here that these are the unadjusted incidence rates for all-cause death, just looking across quartiles of the different sphingomyelins and ceramides here. We see that with increasing quartiles of ceramide 16-0, we're seeing an increased unadjusted incidence rate for all-cause death. These are unadjusted, they're likely to be confounded, so take it with a grain of salt. We'll get into the Cox regressions a bit later. This is looking at the long-chain ceramides and the risk for cardiovascular death specifically. And here the suggestion of a graded association is stronger. These are our Cox regression analyses. These were adjusted for multiple factors, demographics, baseline comorbidities, lab values, intervention arms. So these were kind of our final adjusted models. And we saw that sphingolipids were, in fact, strongly associated with risk of all-cause death. We see that ceramide and sphingomyelin 16-0 were associated with increased risk for death, and sphingolipids associated with or isolated to very long-chain fatty acids, that is 22-0, 24-0, and sphingomyelin 20-0, associated with a decreased risk for death. If we look then at cardiovascular death, everything's in the same direction, only the strength of the associations have changed, and they've kind of changed for the better, stronger associations, that is to say. We see here that each doubling of sphingomyelin 16-0 was associated with about a 4.3-fold increase in your risk for cardiovascular death. And then sphingomyelins, 22 and 24-0, very protective or associated with a very protective effect, as to say, against cardiovascular death specifically. In looking at non-cardiovascular death, things are kind of in the same direction, but these associations are nominal. None of these sphingolipids passed a false discovery rate of 0.05 for statistical significance. So although there's some associations between ceramide 22-0, 24-0, and decreased risk of all-cause death, non-cardiovascular death, these associations were not statistically significant, which might strengthen our hypothesis that these deaths were mostly cardiovascular. I tried to summarize this when looking at the sphingolipid subclasses, and here we see that the hazard ratios for all-cause death are kind of falling halfway between those for cardiovascular and non-cardiovascular death. These associations are all about what you'd expect based on our prelim studies, the things that we showed you just before. But still, again, shown in this figure that most of the death events seem to be cardiovascular and driven by that hazard ratio. I wanted to touch briefly on the ceramide risk score. This is something that's gained traction in general populations recently, and it's a method for kind of assessing your overall ceramide, metabolism, functionality. It incorporates 4 different ceramides. That's 16-0, 18-0, 24-0, and then the ratio of each one of those divided by 24-0, which is thought to be cardioprotective. Basically, you get 1 to 2 points in each of these 6 categories, so you can have 0 to 12 points total, and that's based on your quartiles of these things. So if your ceramide 16-0 is in the first 2 quartiles, or less than the 50th percentile, you get 0 points. If it's in the 3rd quartile, you get 1 point, and greater than 75th percentile or the 4th quartile, you get 2 points. And so it goes for each one of these 6 categories. You total up your score across all of these categories, and that's your ceramide risk score. We developed these quartiles in the hemo study specifically, and these numbers kind of match up with what we see in general populations. About a third of participants were in each of the 2 lower ceramide risk score risk groups, and maybe a sixth overall were in each of the higher risk score categories. And as we look here at increasing ceramide risk score, we see increasing risk for all-cause cardiovascular and non-cardiovascular death. So the big takeaway here is doesn't matter how you slice it, ceramides and sphingomyelins with long-chain fatty acids seem to be associated with an increased risk for all-cause and cardiovascular death. So I had to come back to this tortured analogy because I'm a huge Star Wars fan. The Sith pictured here is actually Darth Revan. He's a fascinating character. He was initially a Jedi Knight. He fell to the dark side. He was later redeemed and became a Jedi Knight again. And this visual character arc is symbolized by his use of both purple, or light side, and red, or dark side lightsabers. I thought that was analogous to the sphingolipids. So on the one hand, you've got sphingolipids with long-chain fatty acids. They're associated with an increased risk for negative outcomes. On the other hand, you've got those with very long-chain fatty acids. They're associated with a decreased risk for these same outcomes. And it's not really clear why we see diverging effects with different length of fatty acid chains. There's some thoughts out there, though. Firstly, those sphingolipids with with long-chain fatty acids might be associated with activation of pro-apoptotic pathways, both the intrinsic and the extrinsic, Josh, pathways. So here we see some data that ceramide and sphingomyelin 16-0 could activate the Cas8-9, Cas3 cascade, or the PP2A BCL2 BAD pathway to contribute directly to apoptosis. Or they might act through the BCLX pathway to induce mitochondrial instability and then also lead to apoptosis intrinsically. We're not entirely sure why sphingolipids with very long-chain fatty acids might be associated with decreased risk for negative outcomes. There's a couple of ideas. First, these very long-chain ceramides could incorporate into the phospholipid bilayer and increase the stability by increasing the van der Waal interactions of the long hydrophobic chains, and that could increase the membrane stability overall. Second, these long chain or very long chain sphingolipids, they might just compete with the long chain or 16-0 species ceramides and sphingomyelins. for binding at the pro-apoptotic cascades, and you could decrease the pro-apoptotic signaling just through simple competition. So in conclusion, we've shown that greater sphingolipids with long-chain fatty acids were associated with an increased risk for death in dialysis patients, and those with very long-chain fatty acids were associated with a decreased risk for death in this same population. And these deaths seem to be mostly cardiovascular death. I'd like to think about for a second what, if any, are the clinical implications of these findings. Are these sphingolipids ready for prime time? And honestly, I think this is a little bit early. There's some thought about whether sphingolipids could be used as a risk score, like using the ceramide risk score in this population. And I think it's just a little bit early. While this study is internally valid, a lot of dialysis populations do not look like the hemo trial population. So I think it's going to take a lot more time to generalize these findings to larger dialysis populations. Also, there might be ways to look into ways to alter sphingolipid levels in dialysis patients, and this might perhaps be a more interesting area of research in the short term. So maybe trying to find some way to intervene on sphingolipid levels could be an interesting next direction. And in line with that, there are data in the hemo study looking at your 48-hour dietary diary and your levels of sphingolipids. So that might be an interesting next direction. Similarly, the cardiovascular outcome that we had was kind of lumped together for different types of cardiovascular disease physiology. There are hospitalization data in hemo, and some patients had more than one event. So it's possible for us to use these sphingolipids to look at risk for hospitalization for each subtype of cardiovascular disease and see if we could get a little bit more power to look into specific cardiovascular pathophysiology here. So this area of research is very highly collaborative and very multidisciplinary, and I owe so much. I owe everything to my incredible mentors and collaborators at the UW and the KRI. This includes Dr. Bonsall, Dr. DeBoer, Dr. Zelnick, Hoofnagel, Rosen-Lamater in general internal medicine. I'd like to thank Raj and the division at large for supporting me, even when grant funding has been uncertain. I'd like to thank the UW ITHS and NIH for supporting my current research, and to all of you for taking time to listen to me talk about sphingolipids and Star Wars today. It means a lot to me. So again, I'd like to close, show you some cute pictures of my kids. Thank you for coming to the talk and take any questions.
All right. Thank you so much for that, Ben. Really wonderful talk. We have a few minutes for some questions if anyone has any. I guess I had a question, Ben, if I'll wait for others, but I'm curious, well, maybe two questions. One, do we have ways of measuring these sphingolipid levels in our patients, and should we, if so? And I guess number two, kind of in looking over the different studies, did you come across any differences in sphingolipid profiles based on both different types of dialysis, whether it be peritoneal dialysis versus hemodialysis, or different degrees of dialysis being done in prescriptions?
Yeah, that's a really great question, Dan. Thank you for asking. I'll address the first part of it first. Do we have good ways of measuring these? Kind of. It really is dependent upon center. So Andy Hoofnagel has a lot of expertise in measuring these sphingolipids. He's done it in a bunch of studies. He knows the calibrators to use and the factors to scale them to. So he can do it at NORC. There are panels out there. Metabolon offers one that will allow you to measure these sphingolipids. We're not sure if they match up perfectly with like targeted LCMS/MS techniques. So I think this is an ongoing area of research. It's still kind of expensive, not available everywhere. And again, I don't think this is ready for prime time just yet, but there are increasing ways to measure these sphingolipids. Second question, you asked if there were any people looking at like hemo versus peritoneal dialysis, and unfortunately, not to my knowledge. I don't know of any other studies actually that look in dialysis period at sphingolipids. So this is kind of the first and largest in hemodialysis, and we did not look at any peritoneal dialysis patients, but I think that's a fascinating question. because there's this thought that inflammation could, induce ceramide and sphingomyelin biosynthesis, and could that be implicated in some way? There, are thoughts about varying degrees of kidney dysfunction. I did not show the data for time, but it seems that as compared to like younger, healthier general population non-kidney failure studies, we see more ceramide and sphingomyelin 16-0 in these dialysis-dependent patients, and perhaps less of those sphingolipids with very long-chain fatty acids. Again, I don't have those data like right to hand, but thanks. That's a great question.
No, thank you.
Ian.
Nice work, Ben. You started off with this example of how sphingolipids within myocardial cells can cause toxicity and damage. And of course, you're looking in the circulation. Can you remind us how sphingolipids, well, first of all, is it the circulating sphingolipids that are potentially causing problems, or is it when they get into cells? And can you remind us how they get into cells?
Yeah, great question. We're not entirely sure. All of these studies in the general population are looking at circulating sphingolipids, so ceramides and sphingomyelins, and those are mostly riding around in lipoproteins. So there's the thought that if they're riding around on lipid rafts, they might incorporate as the LDL or HDL binds to the surface of these cells. The lipid rafts and their components can shift over to the phospholipid bilayer of the target cell. And then some of these can actually leach directly through the phospholipid bilayer. Ceramide can. Sphingomyelin can be converted through exogenous sphingomyelinases to ceramide and then leach directly into the cell. And then there are some cell receptors that will allow the uptake of these as well, or direct uptake of lipoprotein particles. So there are ways, mechanisms for exogenous lipids to get into cells, but it remains an ongoing area of research.
Could I ask one more question as well?
Lucy.
Sorry, I'm having trouble finding my raised hand for some reason. Uh, Ben, I'm curious about the dietary hypotheses that you've proposed for next directions. What sort of what are your hypotheses specifically in terms of what type of diet intake could alter
Yeah,
sphingolipids?
that's a great question. It's an up and coming area of research, and there's not a ton of research on it. We're fortunate to work with Hyunju Kim here at the UW. She's a dietitian. She has, I think you and I are actually on one of her proposals together. She has a lot of expertise in this realm. And she's offered up some really great ideas as to whether more pro-inflammatory diets or those with like a higher endogenous acid load could be associated with alternating sphingolipid productions. There's also the thought that if you increase your overall carbohydrate intake or saturated fatty acid intake, that those could increase the substrate required to produce the long chain sphingomyelin and ceramide species, so the sphingomyelin and ceramide 16-0 specifically. So my hypothesis would be that diets more enriched in saturated fatty acids and perhaps carbohydrates would be associated with greater circulating concentrations of ceramide and sphingomyelin 16-0. Question from Josh in the chat might be on a different thread. I apologize.
Yeah. All right. Any other questions or comments for Ben? Yes, there's ongoing discussion in the chat regarding our previous talk from Josh. So please have a look at that as well. All right. Well, thank you so much for that talk as well, Ben. And I think we can move on to our last speaker,